All right, we're going to look at some review questions here pertaining to gastroenterology. So question 1 gives us a 31-year-old male presenting to the clinic complaining of substernal pain that comes and goes and has been happening for the past 4 months. He has noted that it gets worse after meals. It is associated with a sour metallic taste in his breath. He's attempted over-the-counter antacids, but to no avail. He does not eat before bed and denies alcohol or tobacco use. He denies difficulty swallowing, weight loss, or blood in the vomit. His physical exam is unremarkable. Which of the following would be the next best step in the management of this patient? A. Calcium carbonate, B. Omeprazole, C. Electrocardiogram, D. CT scan of the chest, or E. Esophageal gastroduodenoscopy or EGD. So I'll give you some time to pause here. And the answer to this one is B. Omeprazole. All right, so here we have a young man. He is presenting with very classic GERD, gastroesophageal reflux disease. So he's got all the signs. He's got substernal pain. If you were to ask him where the pain is, he would point to his chest or maybe a little lower, a little higher. But he'll describe this as a burning sensation that comes upward. And what's classic with reflux disease is that it gets worse after meals, of course, because there's more content in the stomach, and that content then ultimately regurgitates upward in the esophagus and up. It's also associated with a sour metallic taste, that's the stomach acid in his breath, and then what we note here is that he does not have any modifiable risk factors, so I guess I didn't include his weight here. Obesity or being overweight is a risk factor, but then also eating before bed can cause reflux disease at night, especially because when you're laying down, you have less gravity pulling the gastric contents down, and so that's going to increase your risk of having episodes. But also alcohol or tobacco use, those also increase your risk. Caffeine, chocolate, all of those things increase your risk. These are all modifiable risk factors. So he doesn't have any of those modifiable risk factors, and that would be our first step to managing reflux disease, would be to modify those risk factors. He doesn't have any difficulty swallowing, he doesn't have weight loss, doesn't have blood in the vomit. Those would all be red flag signs, especially if he was over the age of 45. At that point, we would probably do an EGD because we're more worried about cancer. His physical exam is unremarkable, so at this point we're left with A through D. Calcium carbonate would not be useful in this patient. That's something you can get over the counter. He's already tried that. Electrocardiogram would probably not be the best choice in this patient just because he's young. We would look at an EKG if we were worried about possibly a cardiac cause behind this. If a patient was older than 45 or 50, we might get an EKG because it's cheap, it's easy to do, but we're not really worried about that with him. We're thinking because this is classic reflux disease presentation that this is pretty much for sure reflux disease. Now, the question is how to manage it. CT scan of the chest is not going to be useful at all here. So we're left with omeprazole. Of course, you can substitute in any other proton pump inhibitor, pantoprazole, lansoprazole, doesn't really matter, but we'll go with omeprazole. You could try one of the H1 antihistamines, those work too. But proton pump inhibitors, in my opinion, would be the best step to go with. And I didn't give you any H1 inhibitors here, so you don't have to be confused. All right, so question 2 gives us a 31-year-old male presenting to the clinic complaining of substernal pain that comes and goes. You can see this is the same patient. It's been happening over the last 4 months. He notes that it gets worse after meals, sometimes associated with a sour metallic taste in his breath. He's attempted OTC antacids, but to no avail. He does not eat before bed and denies alcohol or tobacco use. He denies difficulty swallowing or blood in the vomit. His physical exam is unremarkable. However, he has lost 5 pounds in the past month. We'll say that's unintentional weight loss. Which of the following would be the best next step in the management of this patient? A. Calcium carbonate, B. Omeprazole, C. Electrocardiogram, D. barium swallow, or E. Esophageal gastroduodenoscopy, EGD. Alright, so this is the same patient. but one thing is different. All right, so I'll let you pause. And the answer to this is D, a barium swallow. All right, so the difference in this patient, and it's a key difference, is that there's been unintentional weight loss. Now, 5 pounds of unintentional weight loss, well, maybe the patient has changed something, doesn't know, maybe it's due to his vomiting, but the fact is there's been unintentional weight loss. And anytime there's unintentional weight loss, especially in the setting of something that could theoretically be cancer, or is a cancer, you have reflux disease, cancer is associated with reflux disease if you have it long-standing. Anytime that happens, that raises a red flag, and this is indeed what we consider a red flag in the presence of GERD. So this unintentional weight loss makes us much more concerned. We want to investigate it. So we're not simply going to dole out medication here. We're going to do some investigating of our own. Now, if you answered EGD, you're partially right in that we do need to do an EGD on this patient, but the first thing we're going to do is a barium swallow. The gastroenterologist is going to want to know where this tumor may be, if there is a tumor, so that when he or she goes on to do the endoscopy, they're aware of that, because the last thing you want is to puncture, rupture the esophagus. We'll want to know if there's any mass anywhere. So we'll do a barium swallow first. That can give us some idea if there's possibly a tumor there. And then after that, for sure, no matter what, you're going to go on and do the EGD. Why? Because we want to look for other things, such as Barrett's esophagus. So we'll want to take a biopsy. And so EGD certainly will be something that we do, but the next step is going to be a barium swallow first. It gives us a roadmap so we know what we're doing before we do it. So our upper GI alarm symptoms are being over the age of 45, weight loss, as we saw in this patient, anemia, heme-positive stools, dysphagia, odynophagia, or long-standing GERD. So something in terms of years rather than months. So if any of these are present, then EGD is something that you'll want to consider or want to do, especially if it's things like weight loss or anemia or certainly heme-positive stools or dysphagia. So these are what we consider red flags, upper GI red flags, or upper GI alarm symptoms. You'll hear gastroenterologists refer to these alarm symptoms pretty frequently. Question 3. A 35-year-old female presents to the clinic with a recent history of abdominal discomfort. She says that this comfort is generally accompanied by significant gas and occasional diarrhea. These episodes have come and gone over the past several weeks. She has not noticed any blood in the stool, she is otherwise healthy, and she has no fever or weight loss. Presently, she has no abdominal discomfort. Physical exam is unremarkable. Stool guaiac is negative. Which of the following is the most likely diagnosis in this patient? Is it A, inflammatory bowel disease, B, irritable bowel syndrome, C, lactose intolerance, D, foodborne illness, or E, celiac disease? And I'll say so it does say the past several weeks. Okay, good. So she said diarrhea over the past several weeks. Give you some time. The answer is C, lactose intolerance. So this is a patient who's had chronic diarrhea, meaning diarrhea that's lasted longer than 2 weeks. So in that case, we're going to shift away towards the infectious causes and more towards some of the malabsorptive causes, or possibly inflammatory bowel disease or irritable bowel syndrome. Now, since this patient does not have bloody diarrhea, that tends to help us rule out inflammatory bowel disease, but this patient does have significant gas and diarrhea that accompanies that. So some of the things we start thinking of are celiac disease or lactose intolerance. With celiac disease, there tends to be a little bit of blood in the stool. Usually it's blood that can't be seen, and so a stool guaiac is going to be important to differentiate that to see if this possibly is celiac disease. Usually with celiac disease, you're going to have some level of weight loss because there's going to be a significant enough malabsorption. So this patient neither has a stool guaiac, nor does she have a weight loss. But she does have the significant gas and occasional diarrhea. And one of the most common cause of chronic diarrhea is lactose intolerance. And so that's the answer here. We rule out inflammatory bowel disease and celiac disease because there's no blood. Irritable bowel syndrome is ruled out because generally with irritable bowel syndrome, the diarrhea comes and goes. And also with irritable bowel syndrome, it's primarily a pain syndrome. Lactose intolerance is the most likely here. Foodborne diarrhea is not likely just because of the how long this has been happening. Generally, foodborne diarrhea, foodborne illness lasts for less than 2 weeks, and usually is also accompanied by a fever. So question 4, a 52-year-old woman complains of epigastric pain. The pain is well localized, non-radiating, and is rated at a +7 out of 10. She says that a glass of milk or some bread helped the pain, but will come back within an hour or two. Her medical history includes emphysema, obesity, and osteoarthritis of the knees. On physical exam, there is mild epigastric abdominal tenderness, rails bilaterally, but otherwise the physical exam is unremarkable. Which of the following is the best next step in diagnosing the cause of this patient's abdominal pain? Is it A, esophageal gastroduodenoscopy or EGD, B, serologic test for H. pylori, C, serum gastrum level, D, barium X-ray, or E, abdominal CT? And the answer here is EGD. So again, this is simple. We have a 52-year-old here. Anytime you've got a patient that's older, that's having some significant upper GI symptoms, you're going to do an EGD. So this is an older patient, and she's got pain. She's got epigastric pain. So the fact of the matter is we want to look for cancer in this patient. So we're going to do the EGD. This patient, just by being over the age of 45, has alarm symptoms. Okay, so we got the same patient here, and the EGD reveals a 0.5 centimeter duodenal ulcer. After we found the ulcer, we got serologic testing on this patient for H. pylori, and which we always want to do, by the way, and that returned positive. Now let me preface here, if this was a younger patient, we would just go ahead and do the H. pylori test because they would have no alarm symptoms. But since it's an older patient, we went ahead with the EGD. We indeed found the ulcer, so now we wanted to test for H. pylori to see if that's the cause of the ulcer. And indeed, the testing came back positive. Which of the following is the best initial therapy for this patient who has an H. pylori ulcer, or an ulcer and positive for H. pylori? Is it A, metronidazole, clindamycin, and omeprazole, B, metronidazole, amoxicillin, and bismuth, C, clarithromycin, amoxicillin, and omeprazole, D, clarithromycin, amoxicillin, and omeprazole? Oh, that's a repeat there. Oops. Or E, metronidazole, clarithromycin, and bismuth. D is going to be clarithromycin, amoxicillin, and bismuth. Okay, the answer is C or D, actually. So clarithromycin, amoxicillin, and omeprazole. So when we have a patient who is H. pylori positive, we always want to start them on clarithromycin, amoxicillin, and a proton pump inhibitor. So that's going to be omeprazole. We can add bismuth to that if we want, but it's not necessary. But we have to have them on those two antibiotics and omeprazole. So that's the necessity in treating H. pylori ulcers. So the antibiotic therapy for treating H. pylori positive ulcers to eradicate H. pylori, initially we have them on clarithromycin and amoxicillin, and then the PPI, which is omeprazole or any other PPI. And we can add bismuth to that, but we have to have the omeprazole. Now, after 14 days, they've been on those antibiotics, and they are oral antibiotics. If the pain has not gone away or the ulcer has not rescinded, then we're going to switch the antibiotics. We're going to keep them on the omeprazole, but we're going to switch the antibiotics to metronidazole and tetracycline. And so this is the standard therapy for eradicating H. pylori, and you should commit this to memory. Question 5. A 21-year-old man is brought to the ED by his friends after having been found to have vomited bright red blood. He was celebrating his 21st birthday and had been vomiting earlier in the evening, but the friends noted the blood and promptly brought him in. Good friends. While in the hospital, the patient has again had an episode of hematemesis. The patient is drowsy and intoxicated, so the history is limited. His blood pressure is 125/78, his heart rate is 90, his respirations are 13, and his temperature is 98.2. Physical exam is unremarkable. Which of the following is the next best step in the management of this patient? Is it A, barium X-ray, B, abdominal CT, C, EGD, D, consult to general surgery, or E, observation? Okay, and the answer is C. We're going to get an EGD on this patient. So normally, we can go right ahead and do the EGD, but there's something that we have to really make sure of. Anytime a patient is vomiting up blood, we've got to make sure that the patient is hemodynamically stable. This patient has a blood pressure of 125/78, so he is indeed stable. So we don't need to worry about giving fluids right now. We may indeed have fluids started. This patient in real life may have fluids already going in so that in case his blood pressure were to drop, we've already got fluids going in, but it's not the next best step in the management of this patient because he is right now hemodynamically stable. If he were to have a blood pressure of, let's say, 98/62, then we would definitely want to start fluids as the next best step in the management of this patient. But this patient is hemodynamically stable, so the next best step is to go ahead and get the EGD. And that's going to help us affirm our diagnosis, which should be clear to you here that this is a Mallory-Weiss tear. So a Mallory-Weiss tear is a superficial tear of the lower esophagus, and it's not as severe as what's known as Boerhaave syndrome, which I'll talk about in a little bit. Mallory-Weiss tears generally come after retching, after prolonged vomiting, and all it is a tear, a longitudinal tear of the lower esophagus, which causes bleeding, and that bleeding is then vomited up. And so you get prolonged vomiting, which is bloodless, and then all of a sudden you start vomiting again. That retching causes bloody vomiting, so hematemesis. And other physical exam findings are absent. So really all we have is a patient who's throwing up blood, and it's just because he's got a little tear in the bottom part of his esophagus. We diagnose this affirmatively with EGD. We never want to let somebody who's puking up blood to just go without an EGD. That's something that definitely is an indicator for an EEG or an EGD. But we diagnose this with EGD. So this is generally not severe, and provided that there's no other physical exam findings, Mallory-Weiss tears tend to be quite benign. So when we do the EGD, if there's significant enough bleeding, we can use thermal sclerotherapy for the bleeding vessels or the bleeding tissue. But generally, these Mallory-Weiss tears are self-limiting. So with thermal sclerotherapy, all you're going to go in and do is burn that tissue, and it ligates the bleeding. But usually this doesn't require therapy. We do the EGD to rule something else out. Okay, so Boerhaave syndrome is similar to Mallory-Weiss tear in that you do have a tear in your lower esophagus, but Boerhaave syndrome is more severe. It's a transmural tear, so it tears across the entire lumen or the entire thickness of the esophagus. So in this case, you have a transmural tear, and because there's air in the esophagus, what's going to happen is you're going to get air into the peritoneum. So you can get pneumoperitoneum. And this is severe because you can get pain, you can get pneumoperitoneum, you can get subcutaneous emphysema, you can get vital instability. So this can be accompanied by hematemesis, but it doesn't have to be. So these are two different things. They're two different tears of the esophagus, but one is just going to have hematemesis. The other may have hematemesis, but it's also going to have subcutaneous emphysema, vital instability, severe lower chest and upper abdominal pain. Pain right around where that lower esophageal sphincter is. So pain is really what differentiates the two of these. The treatment for this is going to be complex. For Boerhaave syndrome, it's really going to be antibiotics and immediate surgical repair. We'll talk about Boerhaave syndrome in the surgical section. Question 6. A 46-year-old woman presents to the ED complaining of nausea and epigastric pain that came on suddenly after a night of binge drinking with her friends. When you enter the room, you find her sitting up and she tells you that the belly pain is worse when she lays down. The nature of the pain is plus 8 out of 10. It radiates to the back and it's primarily upper left quadrant. Blood pressure is 129 over 82, heart rate's 108, respiration's 18, temperature is 100.8. IV fluids have been started, physical exam reveals epigastric tenderness, and surgical scars from a laparoscopic cholecystectomy that she had 4 years ago. Which of the following is the most likely diagnosis in this patient? Is it A, cholecystitis, B, acute pancreatitis, C, chronic pancreatitis, D, diverticulitis, or E, surgical adhesions? And the answer is B, acute pancreatitis. So this patient has epigastric pain and it came on suddenly, and most peculiarly it's worse when she lays down. So that's something that's kind of unique to pancreatitis, is that the pain is worse when laying prone, but when you sit up, the pain is better. And that's simply because when you lay down, it stretches the peritoneal cavity, and when you sit up, it's a little bit more flaccid. The pain radiates to the back. When you have posterior radiating pain, that's another thing that should make you think of something in the pancreas. And that's just because the pancreas sits in the back of the peritoneum, the posterior part of the peritoneum. So it sits between the stomach and the intestines, or the stomach and the kidneys, roughly. So that's another thing. Pain radiating to the back should make you think of pancreatic pain. Importantly, IV fluids have been started here, so that doesn't need to be done. We also have a temperature of 108, or 100.8 rather. So cholecystitis is not going to be possible in this patient because she had a cholecystectomy. Chronic pancreatitis is also not going to be likely in this patient because chronic pancreatitis will generally present with malabsorption rather than pain, but it can present with pain. Diverticulitis is unlikely in this patient because diverticulitis will generally present as left lower quadrant pain. And surgical adhesions are unlikely because this patient has a temperature of 108.4. You have pain radiating to the back. You have the pain that's worse when she lays down. This pain came after binge drinking, and she's got nausea with this pain. Something, though, that's important is that surgical adhesions do cause abdominal pain in patients that have had surgery, and that she has had a laparoscopic cholecystectomy, but surgical adhesions are unlikely here just because she's got a fever and she's got a very strong picture of pancreatitis, of acute pancreatitis here. So here we have the same patient again. The nature of the pain is plus 8 out of 10. Blood pressure 129 over 82, etc. IV fluids have been started. Surgical scars are seen. Which of the following laboratory values are most specific for the diagnosis, the likely diagnosis in this patient? So we already know that she's got the pain from after binge drinking. It's epigastric. She's got nausea. The pain radiates to the back. She's got epigastric tenderness. And so which of the following are going to be the most specific to the diagnosis in this patient, which we already saw is acute pancreatitis? Is it the white blood cell count, B, the calcium level, C, the lipase, D, the amylase, or E, the hemoglobin? The answer is lipase. Out of amylase and lipase, lipase is most specific for acute pancreatitis. Question 8. A 49-year-old man presents to the clinic with diarrhea that has persisted over the last few weeks. He says that he has tried various over-the-counter remedies to no avail, and the diarrhea has persisted. He has also lost about 8 pounds in the last month, which he says he hasn't been trying to do. Coincidentally, when he had the cold this past weekend, he noticed that a liquid diet made the symptoms somewhat better. However, once he resumed a regular diet, the symptoms returned. Physical examination is remarkable for a mild pallor. Which of the following laboratory abnormalities is most likely in this patient? Is it A, positive anti-neutrophil cytoplasmic antibodies, or ANCA, B, positive anti-Saccharomyces cerevisiae antibody, or ASCA, C, positive Clostridium difficile stool toxin assay, D, positive stool ova and parasites, or E, positive serum antigliadin assay. And the answer here is E, positive serum antigliadin assay. So this is a patient that has had chronic diarrhea. So what do we think of when we think of chronic diarrhea? We think of inflammatory bowel disease, we think of irritable bowel syndrome, we think of celiac disease, we think of lactose intolerance, and some of those rare infectious causes. This patient has lost 8 pounds in the last month, so that tends to rule out lactose intolerance, and it makes us think more towards celiac disease or inflammatory bowel disease. It also rules out irritable bowel syndrome. And so this patient has a pallor, so we think he may be losing some blood. But what's most unique in this patient is his diet change. His diet changes changed his diarrhea, and it made it better. When he changed to a liquid diet, it made the symptoms somewhat better. And so when we think of diet changes making diarrhea better, we think of either lactose intolerance or we think of celiac disease. And since this patient has lost weight, that tends to rule out lactose intolerance. And celiac disease would make sense here because when a patient's on a liquid diet, they're far less likely to be consuming grain or wheat products, which have the gliadin in it that would trigger the inflammation. And so this switch to a liquid diet was likely a switch to a celiac-friendly diet in terms of saying. So this patient likely has celiac disease, and so it's most likely that he's going to have a positive serum antigliadin assay. There's also tissue transglutaminase would be another assay for celiac disease. The positive ANCA would be more likely in ulcerative colitis. The positive anti-Saccharomyces cerevisiae antibody would be more likely in Crohn's disease. The positive Clostridium difficile stool toxin assay would be most likely in the antibiotic-associated diarrhea or C. diff diarrhea, and positive stool ova and parasites would be more likely in a patient that's got a parasitic cause of diarrhea, namely Giardia. All right, question 9. A 27-year-old female presents to the clinic with abdominal pain, fever, and malaise. Recently, she returned from a mission trip in southern Mexico. She said at that time she did dine at one of the local restaurants there. On physical exam, there is abdominal pain, which is primarily located in the right upper quadrant. You also note mild scleral icterus. She denies IV drug use, unprotected sex, and is in otherwise good health. Blood pressure is 126/83, heart rate is 95, respirations is 15, and temperature is 100.8 degrees Fahrenheit. On labs, you get a elevated ALT and AST. Which of the following is the most likely diagnosis in this patient? And the answer here is going to be A, hepatitis A. So primarily when we think of hepatitis, we think of hepatitis A, B, and C. D and E are less common to come across. So A, B, and C, out of those, B and C, and D for that matter, are the hepatitis that are bloodborne. So those are going to be sexually transmitted. They're going to be transmitted maternal fetally. They're going to be transmitted through IV drug use and so forth. Hepatitis A, however, is foodborne. So that can be contracted through contaminated water. Hepatitis A and hepatitis E, they can also be sexually transmitted diseases like B, C, and D, but that would be from oral anal contact. So B, C, and D would be through contact with seminal fluid or bodily fluid. A and E would be through oral anal contact. But in this case, the patient got hepatitis A from what was probably bad water or uncooked food. So hepatitis A is foodborne, and southern Mexico, any third world country, is going to be a possible place to get hepatitis where there's bad fluid maintenance. And she has all the symptoms of hepatitis. Of course, you didn't have any other choice but hepatitis. But the pain is primarily located in the right upper quadrant. She's got signs of jaundice, and she's got elevated ALT and AST, which those ALT and AST lab values should be around 3 times the upper limit of normal. So the answer here is hepatitis A. A 46-year-old female presents to the clinic complaining of mild abdominal pain and, quote, fullness. She says that this has persisted for at least 3 weeks and has gradually worsened. She is in otherwise good health besides a diagnosis of Sjogren's disease, which is effectively treated with artificial tears. She drinks 2 glasses of wine per night. On physical examination, you note a distended abdomen with positive fluid wave and visible superficial veins. There is also some mild peripheral edema. Which of the following is the most likely diagnosis in this patient? Is it A, hepatitis A, B, alcoholic cirrhosis, C, primary sclerosing cholangitis, D, primary biliary cirrhosis, or E, non-alcoholic fatty liver disease? And the answer here is going to be D, primary biliary cirrhosis. So this is a patient that has what's most prominent here is ascites, so that's causing the abdominal pain more than likely, and definitely this fullness. And if you were to look at this patient, you would definitely know that she has ascites. I tried to describe it as well as I could. A positive fluid wave is a physical exam finding. You place your dominant hand or your non-dominant hand, whichever you want, on the midline of the patient by their belly, and then you press on the side of their belly, and you keep your hand there, and if you feel fluid pushing back after you press, then that's a positive fluid wave. All you're doing is testing for fluid to splash up against one side of the peritoneum and press up against the other side, and that's your fluid wave. Visible superficial veins is the spider angiomata, but you'll see blue veins superficially. That's a sign that there's vascular congestion, which would be present in the presence of ascites. And then the mild peripheral edema is another sign that there is some kind of cirrhosis going on. So hepatitis A is unlikely because this has been going on over the last 3 weeks and there's no history of travel. Alcoholic cirrhosis is not likely because she drinks 2 glasses of wine per night. That's not enough to get alcoholic cirrhosis. Primary sclerosing cholangitis is less likely for a reason that I'll talk about in a little bit. Primary biliary cirrhosis is most likely because this patient has an autoimmune disease. Non-alcoholic fatty liver disease is less likely simply because this patient has an autoimmune disease. So the fact that this patient has cirrhosis, has ascites, and she also happens to have no risk factors for cirrhosis, and she has cirrhosis, and she has an autoimmune disease, makes primary biliary cirrhosis likely. Primary biliary cirrhosis is a biliary tract disorder that causes cirrhosis, and it occurs in middle-aged women. It can occur in anyone, but it most commonly occurs in middle-aged women who have other autoimmune diseases. So you could substitute Sjogren's syndrome with lupus, or you could substitute it with Graves' disease or Hashimoto's thyroiditis. any autoimmune disease could be vitiligo. Any autoimmune disease could be associated with primary biliary cirrhosis. Primary sclerosing cholangitis is associated with inflammatory bowel syndrome, inflammatory bowel disease rather. So that's what makes primary biliary cirrhosis more likely in this patient than primary sclerosing cholangitis. But what I will say is that the presentation of this patient, if you take out the fact that she has Sjogren's syndrome, the presentation of this patient is identical to primary sclerosing cholangitis. If you were to replace Sjogren's syndrome with ulcerative colitis, then the more likely diagnosis would be primary sclerosing cholangitis. So these two diseases are very similar. It's the history that's going to help you tease them apart. Now, we have the same patient here, but now what I'm asking is which of the following is the best next step in the management of this patient? So maybe I should say which of the following is the best next step for the diagnosis of this patient? Is it A, an anti-dsDNA titer, B, an ANCA titer, C, an ANA titer, D, an anti-Smith titer, or E, an AMA titer? I'll give you some time here. And the answer is an AMA titer. So definitively, remember I told you that primary sclerosing cholangitis and primary biliary cirrhosis, like we have in this patient, are very similar diseases. They present the exact same practically. The definitive way to differentiate between the two of them is with an AMA titer. Patients who have primary biliary cirrhosis, which is the one that's associated with autoimmune disorders, will have a positive AMA titer most of the time. Patients who have primary sclerosing cholangitis, which is the one associated with Crohn's disease or ulcerative colitis, will tend to have a negative AMA. So that's the definitive way to tell the two of these apart, these two diseases. Nevertheless, primary biliary cirrhosis was the most likely diagnosis because this patient has an autoimmune disorder rather than an inflammatory bowel disorder. The other four, anti-dsDNA tends to be seen in lupus. ANCA tends to be seen in multiple different diseases, but particularly we'll see it in ulcerative colitis, and we'll also see it in various other autoimmune disorders, including Wegener's granulomatosis. ANA is also seen in many different autoimmune disorders, and anti-Smith is seen a lot in lupus. I think that's the more specific one in lupus. Whereas in lupus, anti-dsDNA is. Okay, so 11. A 46-year-old female presents to the clinic complaining of fullness. This is the same patient. She's otherwise in good health, but she's got the symptoms of ascites here. She's got Sjogren's disease, which is treated with artificial tears. She drinks 2 glasses of wine per night. Physical exam is showing very clear ascites with a distended abdomen, positive fluid wave, and visible superficial veins. And there's also some mild peripheral edema. So this is the same patient here, but now the question is asking which of the following is the most accurate test in the diagnosis of this patient. So on the USMLE, you can get questions that give you a patient. They've got a presumptive diagnosis, but it's not asking you what is the best first step in the management of this patient or what is the best therapy in the management of this patient. It's asking you which of the following is the most accurate test in the diagnosis of this patient. Best first test would mean the first test that we start out with. The tests that we would start out with to diagnose this patient would be liver panel, to look for elevated alkaline phosphatase and GGTP. And then after that, we would do an AMA titer. As far as therapy, we would use ursodeoxycholic acid or liver transplant. So we know already from previous questions what this patient has, but now we want to know what is the most accurate test to diagnose that. Is it abdominal ultrasound, liver biopsy, abdominal CT, ERCP transhepatic cholangiogram, or abdominal x-ray? And the answer is B, liver biopsy. So liver biopsy is the most accurate test for diagnosis of the vast majority of liver diseases. The one prominent exception is going to be primary sclerosing cholangitis. Now, this patient has a syndrome that looks like primary sclerosing cholangitis, and it very well could be primary sclerosing cholangitis, but we already found out that this patient is AMA negative, AMA positive. And so this patient has primary biliary cirrhosis. Now, I did these questions on here so that you could see the same patient over and over again. On the USMLE, they generally don't do that. They would say the patient is AMA positive, which of the following is the most accurate test in the diagnosis of this patient. They would have to give you that. But because you already know that this patient was AMA positive from the previous questions, then you know that this patient has a presumptive diagnosis of primary biliary cirrhosis, in which case the most accurate test is liver biopsy, as it would be in hemochromatosis, as it would be in liver cancer, as it would be in non-alcoholic fatty liver disease, and so forth. The exception with liver pathology, when you want to know the most accurate test for the diagnosis, is with PSC, primary sclerosing cholangitis. So that would be a similar vignette to this patient, except they would be AMA negative. And instead of a diagnosis of Sjogren's disease or Hashimoto's thyroiditis or any of the other like vitiligo or any of the other autoimmune disorders, the patient with PSC would have a history oftentimes of ulcerative colitis or of Crohn's disease. In that case, then, if they were AMA negative, then you would do an ERCP or transhepatic cholangiogram. That's the only time that a liver biopsy is not the most accurate test and diagnosis of a patient with a liver disease. It's when the patient has PSC, but this isn't that patient. This patient has PBC. Question 12. A 67-year-old man presents to the clinic complaining of fullness in his chest and points to just below his costal margin. He says that when he eats, he feels the food doesn't get down completely. Occasionally, he regurgitates the food that he's eating and it is not digested. Apart from some occasional heartburn, which is alleviated from antacids, he is otherwise healthy. Physical examination is unremarkable. Which of the following is the most appropriate next step in the management of this patient? Is it A, abdominal CT, B, barium esophagram, C, EGD, D, 24-hour pH testing, or E, abdominal x-ray? Okay, pause it if you want. The answer is C, EGD. Again, this is a patient with esophageal symptoms who also has the, quote, alarm symptoms. Just for the fact that he's over the age of 45 means this guy's getting an EGD. Not to mention, he does have dysphagia, which itself is an alarm symptom, so this guy's bound to get an EGD. We don't know if that dysphagia is caused from a tumor, if it's caused from a stricture, if it's caused from a ring or a web. We don't know what it's caused from. So we want to visualize the esophagus, particularly to rule out a tumor. Because after the age of 45, or if you have dysphagia, a tumor is possible. Okay, so now we've got an EGD with biopsy, and it came back normal. Now, which of the following is the most appropriate next step in the management of this patient? A, abdominal CT, B, barium esophagram, C, EGD, we already did that, so I guess you can eliminate that, D, esophageal manometry, or E, abdominal x-ray. And the answer here is going to be B, barium esophagram. So what's important here is we know that we've done the EGD, but we also need to know that the likely diagnosis being the fact that he has a fullness in his chest and he points to below the costal margin means that this food is getting stuck somewhere in the lower esophagus. So we know that we need to get a barium esophagram because we need to visualize the lower esophagus. We can't visualize it any other way than a barium esophagram. Now, the reason I highlighted the fact that he's eating food that's not or that he's regurgitating food that he's eating and it's not digested is because that's going to help us differentiate between two different kinds of regurgitation. There's a regurgitation that can happen because the patient doesn't get the food into their stomach and it's getting stuck right by the stomach. And there's also a regurgitation that can be forced, meaning the patient can actually express their regurgitation if you ask them to. And that food with that disorder is going to be food that was eaten a long time ago. So in patients with Zenker's diverticulum, what they have is part of their esophagus gets stuck behind their cricothyroid muscles. And so they get a little diverticulum that can trap old food. It can trap food that you're eating and it gets stuck there for a long time. It gets digested and whatnot. And it actually gets putrid and spoiled smelling. And the patient will have bad breath and they can regurgitate that food. The fact is that this patient is regurgitating food that he is eating. And so that's what I wanted to point out here, is that that's going to help us differentiate the fact that this patient does not have a Zenker's diverticulum because this patient is regurgitating food that he is eating, and it's not digested. So anyway, either way, whether we think it's a Zenker's diverticulum or we think it's something else, we're going to get a barium esophagram. So this is what the barium esophagram reveals. So question is now, what is this? Is it A, achalasia, B, diffuse esophageal spasm, C, gastroesophageal reflux disease, D, idiopathic dysphagia, or E, gastroparesis? Now once you see this again, and the answer is going to be A, achalasia. So this patient has the bird beak's esophagus, comes to a narrow tapering, and the fact of the matter is, right here is where the lower esophageal sphincter is. That lower esophageal sphincter is tight. It's not letting any barium in. It's not letting food in. And this patient cannot get food from his lower esophagus past the lower esophageal sphincter and into the stomach, and that's causing the fullness. So this patient has achalasia. So this patient has achalasia. We've gotten the barium esophagram. Now we want to know which of the following is the best initial therapy for this patient. Is it A, omeprazole, B, botulinum toxin injection to the lower esophageal sphincter, and that would be done by endoscopy, C, nifedipine, D, metoprolol, or E, erythromycin? I'll pause it here. And the answer is nifedipine. We use calcium channel blockers for the medical therapy of achalasia. Omeprazole would be used for gastric reflux, which is not what this patient has. D-metoprolol, that's a beta blocker. That has no use here at all. E-erythromycin, that would be used for gastroparesis, which is where the food would get stuck in the stomach rather than in the esophagus. Gastroparesis tends to present with vomiting, and it's vomit of stomach content. So you have not just regurgitation, which is chewed up food, you have stomach content. So it's acidic. The patient says, I'm vomiting, rather than I'm coughing up food that I ate. So nifedipine is the answer here. The second line of therapy, if calcium channel blockers fail, is to go ahead and inject Botox into the lower esophageal sphincter, and that will relax the esophageal sphincter. The problem with that is that these patients will usually have to come in every 6 months to get repeat therapy, and botulinum toxin injection tends to relax the lower esophageal sphincter too much, and so these patients can actually go into gastroesophageal reflux disease, which is the opposite of achalasia. It's a lower esophageal sphincter that's too relaxed. So nifedipine is the first line of therapy, and then if that doesn't work, we'll go ahead and do the Botox injection. Okay, a 72-year-old nursing home resident is brought to the ED because of significant right-sided abdominal pain. It began 2 hours ago and has gotten worse. He's had no significant symptoms until today. Blood pressure is 115/75, heart rate is 105, respirations is 19, temperature is 101.4. Physical exam reveals localized tenderness along the ascending colon. A barium enema x-ray is taken, which shows no signs of pneumoperitoneum. There is some bowel wall thickening and traces of air in the wall. While the x-ray is being read, he passes stool with dark clots. Which of the following is the most likely diagnosis in this patient? Is it A, appendicitis, B, inflammatory bowel disease, C, intussusception, D, bowel wall perforation, or E, ischemic colitis? The answer here is going to be ischemic colitis. So what's most important here is that we know that this is a patient who is possibly borderline septic. He does have a temperature, and that he's got a significant pain. It started suddenly, and that he's got abnormalities on x-ray. He doesn't have a pneumoperitoneum, so that's important because it rules out a perforation. But what he does have are signs of bowel wall changes. And when you have changes in your bowel wall, it shows that there's possibly a circulatory defect to that part of the bowel wall. It can be other things, but the fact that if the bowel wall does not get circulation, you're going to have ischemic necrosis of the bowel wall. And what happens to that when you have ischemic necrosis of any tissue, it releases carbon dioxide, just as the fact that the cells are dying. And when it releases carbon dioxide, that's going to be the air that you see in the wall. And so because you have a bowel wall that's thickened, so we're not talking that the lumen has thickened, we're talking about the bowel wall, the tissue. The tissue is thickened and there's air in the wall. That shows that there's an ischemic necrosis of the bowel wall. Now the lumen itself should actually get narrowed because the bowel wall is thickening, so the lumen will get smaller. And while x-ray is being read, he passes stool with dark clots, and that's a sign that you're getting bleeding into the bowel from the ischemia. And so this all points towards ischemic colitis. Appendicitis would be right lower quadrant pain. Now he does have right-sided pain here, but this patient is unlikely to have appendicitis just for the fact that he has the bowel wall thickening and traces of air in the wall. Inflammatory bowel disease is unlikely, again, because of the findings on x-ray, and also because he doesn't have bloody diarrhea. Passing stool with dark clots is not quite the same as bloody diarrhea. Intussusception tends to be a disease of pediatrics, but there tends not to be a fever. Bowel wall perforation, there will be signs of pneumoperitoneum. And ischemic colitis is the most likely diagnosis in this patient. Let me say, with intussusception, you can have a fever sometimes, so the fever doesn't necessarily rule that out. But ischemic colitis is ruled in because of these x-ray findings. You should be acutely aware of what x-ray findings will look like with ischemic colitis. And ischemic colitis is very common in older patients, unfortunately, and it's generally due to a break-off of a clot that travels down into the mesenteric circulation. Okay, question 17. A 28-year-old woman presents to the clinic with 4-week history of bloody diarrhea, episodes that are accompanied by severe pain and occasional passage of mucus. The bowel movements relieve pain somewhat. Physical examination reveals a tired-appearing female with pallor and pallor of the conjunctiva. There's diffuse abdominal pain in all 4 quadrants, but it's most significant in the right lower quadrant. Bowel sounds are normal, her temperature is mildly elevated at 100.5 degrees Fahrenheit, and you decide to perform a colonoscopy. So why have you decided to perform a colonoscopy on this patient? You decided to perform a colonoscopy on this patient because she's had prolonged bloody diarrhea. So prolonged bloody diarrhea makes us think of 2 things. We remember all the things we think of with chronic diarrhea lasting longer than 2 weeks. Prolonged bloody diarrhea makes us think of either inflammatory bowel disease, or it makes us think of celiac disease. But this woman has had passage of mucus, she's had diffuse abdominal pain, she's had pain that's localized in the right lower quadrant, which is unique to inflammatory bowel disease, and she's had so much loss of blood that she's actually appearing anemic. that makes us think definitely towards inflammatory bowel disease. So we're not going to send this patient home and say, avoid wheat. We're going to perform a colonoscopy on this patient because she is anemic. So we're going to get this colonoscopy, and this is what it shows. So I pointed out here, this is the ascending colon here, this is the transverse colon here, and this is the picture of the rectum. So I didn't get a picture of another part of the rectum that I would have, or of the colon that I would have wanted to, but or of the bowel, I should say, that I would have wanted to, but make your choice here. Is it A, Crohn's disease, B, ulcerative colitis, C, gluten-sensitive enteropathy, D, appendicitis, or E, ischemic colitis? So the answer here is A, Crohn's disease. So it should be clearly Crohn's disease here for you because the rectum's not affected. With ulcerative colitis, it's the opposite. It tends to be limited to the rectum. With either Crohn's disease or ulcerative colitis, it can affect the entire large bowel, but ulcerative colitis tends to be limited to the rectum. But ulcerative colitis will always affect the rectum. Here we see a relatively healthy appearing rectum, but the transverse colon and ascending colon are affected. So because we have an ascending colon and a transverse colon that are affected, it makes us think of Crohn's disease. And if I could have gotten another picture, which I kind of put this stuff together in a hurry, I would have gotten a picture of the terminal ileum. And terminal ileitis is very unique to Crohn's, and that tends to be what causes the significant pain in the right lower quadrant. So right lower quadrant pain can appear in appendicitis, but it's not going to be pain that's occurred over the last 4 weeks with bloody diarrhea. It's going to be sudden pain. Sometimes sudden pain that goes away and then comes back as generalized peritonitis. Ischemic colitis is definitely never going to happen in a 28-year-old woman that's otherwise healthy. Okay, so here we have the same patient. We've diagnosed her with Crohn's disease, and so after we've stabilized her, we want to know which of the following is the best initial therapy in this patient. Is it A, Rowaza, B, Azicol, C, Pentasa, D, budesonide, or E, 6-mercaptopurine? Give you some time to pause here again. And the answer is C, Pentasa. So Rowaza is an enema form of the 5-ASA or of the ASA derivatives. So that we tend to prefer for ulcerative colitis. For rectal disease, Rowaza, R, think rectal. Azicol is another one that's preferred for ulcerative colitis. That's more for the rectum and the descending colon. And so that's also preferred for ulcerative colitis. Pentasa is the whole digestive tract. So that's preferred for Crohn's disease because it works on the entire colon, works on the small intestine, the stomach, the esophagus, the mouth, everywhere in the digestive tract. So Pentasa is the best thing for Crohn's disease as far as the ASA drugs. Remember, the ASA drugs are the first line of therapy for patients with Crohn's disease or ulcerative colitis as soon as they're diagnosed. Budesonide is an oral steroid that can be taken in addition when the patient has a flare. That can be given also in addition for this patient because she's having a flare, but the most important drug, the drug we have to give this patient, is one of the ASA derivatives. So we have to give her Pentasa. We can give her budesonide as well because she's having a flare right now. But more than likely, we would hospitalize her. So budesonide would actually not be the choice. And we'll see this in a little bit. 6-mercaptopurine is a steroid-sparing drug. That's for long-term therapy when the patient is not having a flare. Okay, so the treatment for Crohn's disease or ulcerative colitis. So all patients with Crohn's disease or ulcerative colitis are going to be on the ASA derivatives. That's what I already talked about, which is Azicol, Rowaza, or Pentasa. Rowaza and Pentasa tend to be used in ulcerative colitis, particularly Rowaza. And azole tends to be used in ulcerative colitis, but it can also be used in, Pentasa tends to be used in Crohn's disease, but it can also be used in ulcerative colitis. So any of these drugs are fine for Roaza or Pentasa are fine for Roaza, azole, or Pentasa are all fine for ulcerative colitis, but for Crohn's disease, it's Pentasa. If the patient is having an acute flare, so meaning they're having acute bloody diarrhea, they're in the hospital, we're going to give them IV steroids. So IV steroids meaning not budesonide. We're gonna give methylprednisolone. When we discharge the patient, we can discharge them on steroids. We tend to discharge them on budesonide, or we can give them prednisone. Budesonide is better. It has less systemic effect, so it'll be less likely that we'll see the hyponatremia and hyperkalemia, the weight gain that we would see with prednisone. Over time, we tend to not like to use, we don't use, as far as USMLE is concerned, we do not use steroids for more than 6 months. So if a patient needs steroids for more than 4 to 6 months, we try to shift them off of steroids and onto the steroid-sparing drugs. And the steroid-sparing drugs are 6-mercaptopurine and azathioprine. Before we start a patient on steroid-sparing drugs, we always get TPMT levels first. TPMT stands for something I don't know, but just make sure you know TPMT levels, get that first. And the reason is because TPMT is an enzyme that is going to detoxify these drugs. And some people, about 10% of the population, are deficient in TPMT. And so if we give them 6-MP or azathioprine, they can actually get toxic effects from the TPMT, or from the 6-MP or azathioprine. So we want to make sure that a patient has TPMT enzyme before we give them the steroid-sparing drugs. And this is just a genome test, and it's very easy to get. So steroid-sparing drugs are the next step if the patient has required steroids for more than 4 to 6 months. If the steroid-sparing drugs and ASA derivatives together are not sufficient, so when we start the steroid-sparing drugs, we're continuing the ASA derivatives. If the two of those together are not sufficient, then we're going to use the biologics. And the biologics are more expensive, but they tend to be the most effective. We always want to get a TB test first because the biologics are anti-TNF-alpha drugs, so they can reactivate tuberculosis. So we always want to get a test on tuberculosis for these patients, which is just the PPD test. And if the patient comes back positive for tuberculosis, we are not going to administer these drugs. If they come back negative, we can go ahead and give them infliximab or adalimumab, but they should know that they are at increased risk for tuberculosis among other opportunistic pathogens. So steroids, PO steroids, or IV steroids can be used in the hospital for acute flares, and IV steroids tend to be used for hospital treatment. We'll cover the specifics of this in a little bit. So a 47-year-old woman presents to your clinic for the 3rd time in the past year with complaining of abdominal pain and diarrhea. She says that the bowel movements relieve the pain, but that the pain is severe and interferes with daily life. Stool studies were taken 3 months ago, which were normal. Colonoscopy was performed last month, which was unremarkable besides one small polyp in the ascending colon. A trial of gluten abstinence and lactose abstinence have been tried to no avail. Which of the following is the most likely diagnosis in this patient? Is it A, hypochondriasis, B, somatization disorder, C, Munchausen syndrome, D, irritable bowel syndrome, or E, juvenile polyposis syndrome? And the answer is D, irritable bowel syndrome. So irritable bowel syndrome is a pain syndrome that also has some GI symptoms as well. Particularly what you're going to see with irritable bowel syndrome is you're going to see pain that's relieved by bowel movements. And those bowel movements can be diarrhea, they can be constipation, or they can be diarrhea alternating with constipation. So whenever you see pain that's relieved by bowel movements and everything else has been worked up and is abnormal and is normal, irritable bowel syndrome is the most likely diagnosis. Irritable bowel syndrome, by definition, is a diagnosis of exclusion. So you have to do your entire workup for everything else, all your other chronic causes of diarrhea, all your other causes of constipation, before you diagnose irritable bowel syndrome. And generally, that's going to mean a colonoscopy. Hypochondriasis is a psychiatric disorder where the patient believes they have a disorder that they don't. This patient indeed does have irritable bowel syndrome. Somatization disorder is a pain disorder in which the patient has more than one GI symptom. They also have one sexual syndrome in addition to 4 other pain syndromes, so that's not the case here. Munchausen syndrome is where the patient is faking an illness. That's not the case here. Diarrhea cannot really be faked. Well, it can be faked by taking a laxative, but this is a clear case of irritable bowel syndrome. The bowel movements relieve the pain here. So irritable bowel syndrome is far more likely than Munchausen syndrome here. No signs of Munchausen syndrome in this vignette. And juvenile polyposis is totally different. That's a disorder of having many polyps on colonoscopy. And on colonoscopy, this patient only had 1 polyp. So the Rome criteria for irritable bowel syndrome is abdominal pain that's relieved by bowel movement. So there is actual criteria for irritable bowel syndrome. Abdominal pain relieved by a bowel movement, fewer symptoms at night. So the patient is not going to have the symptoms at night. They're only going to have the symptoms during the day. And when I say during the day, I mean when they're awake. So if they're awake during the night, they'll have the symptoms at night. But when they're sleeping, they don't have the symptoms. Whereas a patient with inflammatory bowel disease, they may get woken up at night and have diarrhea. Bowel movements are often diarrhea or constipation, or they could be alternating, and the symptoms have persisted for more than 3 months. Okay, question 20. 56-year-old man presents to the ED via EMS with ongoing hematemesis. He began vomiting bright red blood 45 minutes ago and has had 2 episodes since, including one in the ambulance. His wife is with him, and she says that he has struggled with alcoholism for the past 15 years and approximates his drinking at about a 6-pack a day. Wow. Blood pressure is 104/58, heart rate is 110, respirations is 19, temperature is 97.4. Which of the following is the next best step in the management of this patient? Is it A, packed red blood cells, B, half normal saline at maintenance rate, C, a bolus of normal saline at full rate, D, immediate esophageal gastroduodenoscopy, EGD, or E, platelet transfusion? And the answer here is C, a bolus of normal saline at full rate. Most important thing when a patient comes in and they're vomiting bright red blood and it's ongoing is that we get this patient fluids. And this patient has a low normal blood pressure, so we definitely want to get fluids into him. So a bolus of normal saline. Half normal saline is not what we use for fluid resuscitation. It's what we use for fluid maintenance. So we use a bolus of normal saline, and we just get that fluid into him as quickly as we can. Packed red blood cells may be good later on if the patient becomes anemic, but as far as resuscitation, packed red blood cells play no role. EGD will ultimately be a step in management in this patient because he does clearly seem to have esophageal varices, but that's not our first step. And platelet transfusion, that's not going to be of use here. So as we approach esophageal variceal bleeding, the first step is to always stabilize the patient, so giving them fluids. Once we've given the patient fluids, we're going to administer IV octreotide, and we're going to prepare the patient for EGD. Sometimes IV octreotide itself will stop the bleeding, but either way, we're going to have to do an EGD on a patient with variceal bleeding. When we do the EGD, we can band the varices, the actively bleeding varices, or we can use scleral ligation. If the banding is unsuccessful, then the next step is going to be TIPS, which is transjugular intrahepatic peritoneal shunt, and all we're doing there is shunting blood away from the liver, so we can reroute blood through the variceal veins. So in that case, we're going straight from the hepatic vein or the portal vein to the inferior to the hepatic vein. And that's going to allow us to reduce the size of the varices. The downside to TIPS is that you do get a decrease in liver function because you're bypassing the liver. So your ammonium could go up and so forth. Blakemore tubes are a common wrong answer. Those are only used in the interim between before we do the TIPS, so between EGD and TIPS, or if the TIPS has not worked, if it's unsuccessful and we need to do invasive surgery. So a Blakemore tube is only a transitional treatment. It's never the right answer on the USMLE. It's only a transitional step. All patients who are diagnosed with varices should be put onto a beta blocker, but important to remember that beta blockers do not help active variceal bleeding. And one more thing that I want to point out here, as far as the treatment for Crohn's disease or ulcerative colitis, when the patient is actively in the hospital for their Crohn's disease or ulcerative colitis, when they're having acute flares, you want to have them on IV steroids. And so IV methylprednisolone is the best steroid to have them on. So if the patient is in the hospital, they should be on steroids. As the patient, we want to monitor their bowel movements. And as their bowel movements get better, as the blood abates, normally we see bloody diarrhea when they come in. As the diarrhea is less bloody, then we can transition them from IV steroids to PO steroids. Their diet can be as tolerated, but the primary goal is to transition them from IV steroids to PO steroids. And we will discharge them on PO steroids, and we'll attempt to taper that down. That's pretty much beyond the scope of the USMLE. But what I really wanted you to get here is that when we admit patients for Crohn's disease or ulcerative colitis flares for their acute episodes, we want to have them on IV steroids, not on PO steroids. And that is the end of the GI review.